talk about why that. Just do this adjustment. Wouldn't be a Zoom session without some technical difficulties, but just to review some objectives for today. We'll hopefully review anatomy and physiology, just so we're all on the same page from that perspective. We'll talk about presentation of diaphragmatic hernias, what your diagnostic approach can be, and then some challenges specifically with anesthetic management, which is going to be very important, and then some surgery objectives as well. Anatomy-wise, we have the central tendon, which takes up about 21%. I know it's not the greatest on the screen image-wise, but it's the yellow circle there. So that's a majority of what the diaphragm's made up of. There are the surrounding muscles. We've got the pars ventralis, the pars costalis on either side, and then that's going to be the pars lumbalis. So that's all of the different muscles and surrounding diaphragm that are important. Talking about the major openings, we've got the aortic hiatus there in the yellow circle, just having a view it on my screen here. We also have the kind of different structures passing through there. You got the caval foramen as well, so that's where the vena cava is going to come through, and then the esophageal hiatus as well. So those are the kind of three important holes that pass through the diaphragm and the structures that pass through them. And then there are some minor openings as well. The paired kind of foramen of Morgani, a little less important, just where some arteries pass through as well. And so this is going to be the view. The ventral is at the top here, dorsal is at the bottom. This is the view you're going to see in surgery. So when you're looking up at the diaphragm while you're doing that kind of abdominal procedure for a diaphragmatic hernia. So we got a kind of what it looks like from that specific view. We've got that central tendon that we just talked about. So it's that kind of white structure kind of in the middle here. We've got the surrounding kind of pars sternalis, which is that kind of top muscle. The costalis, which is going to be on either side, kind of highlighted in red here. And then we've got the left and the right crus, is that kind of dorsal portion when we're on the inside of the abdomen and we're looking at it. So those are two paired muscles that also attach to kind of the spine in that area there. And then we've got that caval foramen, so that's where that vena cava is going to come from. That's going to be your most ventral kind of hiatus that's going to be present. And then we've got their esophageal hiatus, that's where the esophagus passes through to the stomach. And then we've got where that aorta or aortic hiatus is, where that's going to pass through. So just kind of review in terms of blood supply to that diaphragm. We've got the phrenico-abdominal artery that's going to come off and go to the phrenic. And then the phrenic kind of goes to the branch anastomosis where that kind of terminates. And then in terms of the blood supply coming back, from a venous perspective, we have a cranial portion, which is the cranial phrenic to that caudal vena cava. And then we've got the caudal phrenic to the cranial abdominal vein to that comic phrenico-abdominal, and then eventually to the caudal vena cava. In terms of innervation, this is really important from our neurologic perspective when we talk about dogs that present with that kind of cervical disc herniation from that perspective. But that innervation to the diaphragm comes from ventral branches of the 5th, 6th, and 7th kind of nerves coming from that cervical area. So anything that's affecting that from a neurologic perspective is going to affect the innervation to that diaphragm. In terms of physiology, a lot of that is pretty self-explanatory. It really helps with inspiration. When it contracts, it can cause the abdominal viscera to be pushed caudally, which expands the ribs themselves. There is a little bit of caudal rib cage expansion from the costal muscles themselves. So it's not all diaphragm, but a majority of that motion's coming from that muscle. When the abdomen's open, we get a bit of a paradoxical effect, which is where when they inspire, their caudal rib cage actually kind of moves in, which is in the opposite direction we would expect. So just something to be aware of. That chest wall does expand quite a bit. And when there is diaphragmatic paralysis, while yes, there is other muscles that can help with inspiration, the diaphragm does such a major part of that. We do see them affected quite significantly when they have that paralysis and are able to function in terms of their diaphragm. So as we watch this video, as best as we can see it, you can see how it's very short breaths that the dog is doing, but how that chest wall is expanding and the abdomen's kind of moving in that's going to be a normal dog. So that's what it look like just when a dog's laying in lateral. So moving into our diaphragmatic hernias, mainly it's going to be a majority of cases from trauma, usually vehicular trauma when we're talking about dogs. It can happen with any sort of falls from height, anything that compresses the abdomen significantly. When we get that increase in abdominal pressure, we then see that with the glottis open, we get acute herniation. There is a peritoneal, which is going to be your abdomen to pleural, which is your thoracic cavity gradient. That's usually around 5 to maybe 20 centimeters of water. When dogs experience a diaphragmatic hernia, it can get up to like 100 centimeters of water. So it's pretty significant compression that needs to happen for that to be able to herniate through. Usually after it ruptures, we get a bunch of viscera because of that increased pressure that kind of moves into the thoracic cavity because of the herniation. But anywhere from right after injury to weeks to maybe months afterwards, it can be quite dynamic. So it might start with a certain number of organs in the diaphragmatic hernia. It can move back into the abdomen. That free communication causes kind of different things to move into that space. And so this is going to be what it's going to look like. We're jumping ahead to surgery briefly just to get an idea of what that diaphragmatic hernia can look like. This is going to be what the normal diaphragm should look like. There's a nice big hole here that I think everybody can see, which I think the majority of the liver is kind of moved into the chest at this point. So just an idea of what that would look like. And so history is going to be important for these dogs. Obviously, anything coming in with some sort of trauma, we should suspect a diaphragmatic hernia. It's about 85% of dogs and cats presenting for diaphragmatic hernia have a history of some sort of trauma. So that's going to be important to note. A lot of these patients are going to present with respiratory signs, about 38% according to one study. They have an increased rate and effort. A lot of owners will report trouble breathing, which is kind of what we all get triaged to a certain degree. And they can also have concurrent kind of pneumothorax or sometimes pulmonary contusions if there was significant enough trauma. So it's not all just the herniation that's causing the issue. It can also be lung related or thoracic cavity related. So just important to think about. You can do it. See if we can move forward again. Did it freeze on me? There we go. So there can also be some gastrointestinal signs. Obviously, if there's stomach or intestines that move into the hernia, they can have vomiting, regurgitation. A lot of them will also have concurrent abdominal pain because of that. And they can also be inappetent, which tends to be more of a chronic thing. Obviously, they're presenting acutely with vehicular trauma. They're not going to have that inappetence history, but more chronic ones will. So just something to think about. Those GI signs can be nonspecific. A lot of times on your exam, you'll see certain things like we'll call it an empty abdomen, where you're just feeling and you're not really feeling the normal organs that you would when you're palpating. You can get very muffled lung sounds when you're trying to sculpt to the thoracic cavity. The heart apex can be moved to one side depending on how much is herniated through the diaphragm. And then the more obvious thing is if you start to hear borborygmi, which is those gut sounds within the chest, that might also increase your index of suspicion that there might be some intestines sitting within the thoracic cavity. So those are some things that you'll find. Initial stabilization is going to be really important. If they come in looking like the dogs in this picture, certainly providing them oxygen is going to be the most important. I had a criticalist tell me there's really only one reason not to provide oxygen to a patient that's coming back for initial stabilization, and that's if the patient is actively on fire. But usually in those situations, you can still provide nasal oxygen while you're putting out the fire. So very, very important to provide oxygen if they come in with dyspnea. IV access is going to be great, just to provide fluids and medications to these patients. A lot of them require sedation. They just had some sort of trauma. They're being rushed into a hospital. Sometimes giving them butorphanol or something like that can help them calm down from that perspective, but certainly important to monitor them closely. Gravity can work in your favor as well. If they're smaller patients, you can kind of pick them up and give them a little shake. Obviously not significant if they have like a TBI or head trauma from that perspective, but it can help move some of those abdominal organs back into the abdomen to provide them a little bit of relief from that perspective. Your fast scanning can be very important to give us a better idea if there is something like pleural effusion. You can see things like organ displacement. You can see the shadowing of whether it's a liver or something else within the chest cavity. It can be kind of nice to have a better idea that this might be something to consider. And a lot of times there can be kind of incidental organs sitting in there, especially with the more chronic hernias. But you can sometimes see like entrapped intestines, which is going to be filled with gas, things like that. That's going to make that fast scan more difficult. So I'm not clicking fast enough. It does, yeah. All right, so this is going to be pretty obvious in terms of fast scan. We've got the different organs labeled. You can see that liver showing up, the gallbladder is nice and distended, and then you can see the heart kind of shadowing down there. So if you're seeing things like that, diaphragmatic hernia goes to the top of the list in terms of your diagnosis. Baseline blood work, again, going to be important just to kind of assess their overall stability, kidneys, liver. Obviously, liver enzymes are going to be elevated due to that trauma. Mainly, your screening methods for diaphragmatic hernia is going to be your thoracic and abdominal radiographs. We'll go through a lot of those and we'll have a lot of examples. And then if you have availability, a CT scan can give you an excellent idea of maybe where that hernia is located, what is going to be herniated through. Not essential from that perspective, but if they're not quite sure, or if you want to get a better picture of kind of where this hernia is located, that CT scan is going to be very helpful. So on these X-rays, as best as you can see them from that perspective, the best thing to note is on that lateral X-ray, you can see where that diaphragm should end, and you can see there's this nice big shadowing structure that's taking up a majority of the lung field. That's going to be a strong indication that there's likely a hernia there. On the VD, it's not as apparent, so they're not the greatest. This probably came maybe from an RDVM or something, but you can even tell on the lateral X-ray that we've got some good view of what you suspect to be is a diaphragmatic hernia. CT scan here, as we scroll through, it's hard to see for certain, but you can sometimes see this is going to more forward as it scrolls through and you see the heart. This is probably where the normal margin would be. So it seems to be one-sided. So this lateral view from a CT scan perspective isn't the greatest at showing diaphragmatic hernias. But as we move to a more coronal view, you'll watch it scroll through, and it can be pretty obvious that majority of that right side of the thoracic cavity has some colon in there. That's going to be spleen coming into view, and the heart's been pushed off to the side. So depending on the view you're looking at on CT scan, it can be more apparent in terms of which side the diaphragmatic hernia is on from that perspective. Other imaging options, they are possible to help you if you're not quite certain there's a diaphragmatic hernia. Wouldn't necessarily recommend barium. That would be if you're worried about stomach or intestines being in the thoracic cavity. Certainly if there's concern for leakage, we don't want barium leaking out of those intestinal segments that might be compromised. So not ideal, but can be a way to highlight those organs. You can give positive contrast into the abdomen just to kind of give an idea, move them around a little bit to see if that contrast leaks into the chest. Or you can do what's called a pneumoperitoneogram, which is giving just air into the abdominal cavity. And if it leaks then into the chest, you have a strong indication that there's likely diaphragmatic hernia. Ultrasound can be another good way of just doing a screening method. I know we talked about doing a true TFAST or AFAST, but a full ultrasound of the abdomen can show that there's organs missing that are likely in the chest cavity. So if we look at the view here on the left, you can see that they've given some positive contrast. I think this image is going to be best for the people in the room that has kind of leaked into the chest cavity. Same thing down here. You can see it kind of leaking at that point. And the one on the right, it's kind of dark because they gave gas into the abdomen and it's leaked into the chest. So you can see it on that screen here, just to highlight things have herniated. And if we're talking about ultrasound, a normal diaphragm, when you're viewing it, should look like the top image. So you can see a nice, clear, defined line where the liver lives up here. However, in this bottom image, you can see how it's just kind of corrugated and looks very abnormal. You can see the heart very well. Liver looks a little weird. When they talk about kind of viewing it on ultrasound, that's a very kind of telltale sign of what they look for to show that, hey, maybe the diaphragm isn't quite normal and that there's hernia present. Perfect. In terms of the hernia, we do describe it in different ways. We've talked about the location. It can be on the left versus right, or sometimes bilateral if there's more than one area that's had herniation present. The orientation is important, mainly when we're talking about surgery. So circumferential, we'll have a diagram on the next slide, is around the periphery. Radial is going to come from the inside to outside, and it a lot of times is a combination of the two, but that's a different ways that we describe it. And so we talk about the radial tear and coming from the ventral portion here to the central tendon, and that circumferential is going to be just along the outside or around the circumference. And then this is going to be what that combination looks like, a little bit of radial, a little bit of circumferential, which is what's going to happen a lot of the time. We also want to talk about kind of what might be herniated or what viscera is herniated in. It can be liver, small intestines, anything that's going to be within the abdomen can end up in the chest. A lot of these effects are mainly cardiorespiratory because they're affecting the lungs and heart as it pushes things around and compresses things. But sometimes the organs involved can be affected. There can be kind of leakage from a kidney that might have made it too far cranial and disrupted its either blood supply or ruptured its ureter. Or sometimes the biliary tree can be entrapped and it can lead to rupture and leakage. So can sometimes have effects to those organs that might be involved in the hernia. For the liver, we can create a lot of pleural effusion, mainly just because of congestion, and that increased hydrostatic pressure can cause kind of fluid to start to accumulate. Depending on the biliary tract obstruction or not, if that becomes compressed because of how things are laying, that can lead to many more issues, elevations in the bilirubin and sometimes leakage if it becomes bad enough. Another big concern is liver lobe torsion. There's a lot of freedom that happens when the liver is able to herniate into the chest cavity. So if that one of those lobes is to become twisted, you can lose blood supply, and that can become certainly an emergency as well. When we're talking about the spleen, it's also related to spleen issues that are going on in the abdomen. You can get congestion. Sometimes the spleen contors, and that can lead to congestion and loss of blood supply. Sometimes it can necrose if it becomes bad enough. And certainly if the spleen is affected, we can see arrhythmias, like the ventricular tachycardia going on at the bottom of the screen there. So certainly something to note. The main one that people become concerned about is the stomach. Mainly because the stomach, when it's herniated through, can be distended with gas. If that starts to happen, we can see vena cava compression as well as lung compression that can lead to pretty severe compromise. Certainly, if the stomach's distended enough, and if it is to volvulus or can turn over, can lead to ischemic necrosis of the wall and cause an outflow obstruction with the metabolic alkalosis if normal food and everything else is not able to pass through the stomach due to its herniation into the chest cavity. So it's going to be kind of what that compromise looks like in terms of the stomach. A little bit dark purple, maybe some blackened areas on this view. Not really sure if it's going to be viable. A lot of times until we get in there, we can't tell for certain as that blood supply starts to return. So that's kind of what that looks like. If the intestines or the pancreas are in there, it can become entrapped. This is going to be that mesenteric volvulus. It's going to be when it turns dark purple or black sometimes. So if it loses its blood supply, that could be certainly a concern, can lead to things like septic peritonitis. The pancreas, if it gets bad enough, can become inflamed, cause pancreatitis. A lot of these dogs have ileus as well due to the kind of decreased function of those intestines. Perforation, again, not great. And then certainly if the duodenum's involved, it can also lead to biliary obstruction and issues within the abdomen. Certainly other things that can herniate, the omentum's usually no big deal, but that can lead to more adhesions sometimes as it sticks to lungs and other things. The colon certainly can lose blood supply as well as the kidneys, which we've kind of talked about already. So moving into timing in terms of surgery, can be really important to talk about. Initially, when we talked about doing it within 24 hours of presentation, the early thought was that there was some sort of increased mortality rate. Mainly, I think, due to just multiple organ dysfunction and inflammatory response and things related to the organs that were involved. I think we found that that's maybe not the case. When we talk about the more acute presentation, I think we worry about things like gastrothorax, where if the stomach's herniated through, it can become very inflated and lead to things like obstruction of the vena cava, things that we know lead to cardiorespiratory compromise. So a lot of times if we see the stomach and the chest, that can be indication that we need to go sooner rather than later to surgery. And again, more recent reports show a much better survival rate than the initial kind of papers that came out, usually anywhere up to about 89% survival. So very good prognosis, all things considered. Certainly the cost of delay is if we have an otherwise stabilized patient, if we were to wait a prolonged period of time, they certainly can go the opposite direction and become more destabilized, especially with certain organs that are herniated through. If they already get stuck there, that can cause concern of loss of blood supply, things like that. So certainly not going to wait too long, but certainly stabilizing them is going to be very important to their overall ability to tolerate anesthesia in the procedure. The other kind of end of the spectrum is dogs that present after 1 year of documentation of diaphragmatic hernia and are now going to pursue surgery. Again, we initially thought there was also an increased mortality rate for those patients presenting after a year of their hernia. A lot of different clinical signs like GI signs and appetence can be present that aren't going to be seen in those early diaphragmatic hernias. And a lot of times they're incidental. You're taking x-rays for something else and you notice certain things are herniated into the chest cavity that you wouldn't otherwise know about. Certainly, previously reported the mortality rate being in the 62%, sorry. So very high mortality rate. So I was very concerned about waiting on these. However, a lot of more recent literature shows it may be more in the 14%, which is pretty consistent with acute hernias as well. So still a good prognosis, a little bit more things that we have to worry about, but maybe not as bad as we initially thought. So now that we've decided, we've diagnosed our friend, everybody starts running to surgery, getting ready to go on the way. But certainly it's important to be prepared for the anesthesia part of things. That's going to be the most important thing to worry about. Not to say surgery is not important, but anesthesia is going to be where you're going to see a lot of issues arise, especially in that early phase. So pre-oxygenation and giving adequate pre-medication so that these patients are calm during the initial anesthesia phase is going to be important. If you can give them that 5 minutes of oxygen, it's going to make that initial induction a lot smoother. We want it to be as smooth as possible so that we're able to intubate them and protect the airway. And when they are getting put under anesthesia, we want that intermittent positive pressure ventilation so that we can make sure we're expanding those lung fields because we're going to be pushing in against some abdominal organs from that perspective. But we want to be careful, which we'll talk a bit about as well. When they are being anesthetized and we need to reposition them, which we do a lot of times because we have to get them on their back and prep for surgery, is we want to make sure we avoid having the affected side up. If you recall that initial CT scan that showed all the liver and spleen and intestines on that right side, you don't want the dog to be left side down because now all of those organs in the chest are compressing the lung lobes that are actually able to expand. So we want the affected side down, which can make it a bit easier if we know that to know kind of where we need to be careful when they're under anesthesia and we're repositioning them. It can create a pretty significant VQ mismatch, which causes certainly atelectasis and then hypoxemia. If we're not able to get air to those lung lobes, they're not going to be able to ventilate appropriately. You want to avoid any rapid repositioning because that can cause a significant shift in abdominal organs in the chest cavity. And sometimes if you have a little board to put down to kind of elevate their head, that can make it easier when we're starting to prep them for surgery so that those organs are more likely to move caudal as opposed to cranial, where it's going to affect those lung lobes and cause that VQ mismatch. Certainly monitoring important for any anesthetic patient, but we really want to keep an eye on the ECG, especially if the spleen's affected. We start seeing arrhythmias, we might need to treat those. Their pulse ox, as reliable as it can be, we want to make sure that they're able to get oxygen appropriately if we need to reposition them in any way. Certainly monitoring blood pressure and tidal CO2 is going to give us an indication of their stability while they're under anesthesia for the procedure. When they're under, we want certainly controlled ventilation. If we have a high inspiratory pressure, so greater than 20, that can cause issues called the Valsalva effect, which is where if we have them very inflated while we're tying off sutures, especially in the diaphragm, it can create this kind of issues with venous return where they're not able to have adequate blood supply, and we can get VQ mismatch that way. So we just want to be careful when we're doing those inspiratory pressures that we're not pushing them too high. So that's just something to kind of remember. In terms of surgery, if we can clip them and at least prep them a little bit while they're still awake, that can be beneficial, just to make that induction and moving into surgery process smooth as possible. When we're induced and ready to go, you want to make sure you're ready from a OR table perspective, because the sooner we can get in there and reduce those hernia contents, the better stability we're going to have, the better lung expansion and oxygenation. So we want to make sure we get into the OR, maybe have the back table set up depending on how things are, and then covered maybe with like a sterile drape. That way we don't contaminate it as we're rolling in. But having things as ready to go as possible is going to just be of benefit for the patient, because as soon as they're on their back and we're having to ventilate for them, we want to get in there and reduce it so that we can kind of make them as stable as possible. So we just want to be ready to go. Mainly, it's going to be a midline celiotomy, our midline approach to the abdomen. If we're dealing with more chronic hernias where we're worried about how we're going to reduce things, we sometimes need to prep for a median sternotomy. We'll clip a lot of times and still drape it in with the hopes, fingers crossed, that we don't have to go into the chest and do that median sternotomy. But a lot of times if we're having to pull too much or we're worried about adhesions, it's sometimes necessary. When you are reducing the abdominal viscera, you want to be as careful as possible. Some tension's okay. If you're feeling like you're having to yank on it, you're going to end up spending more time in the abdomen, and the dog's going to be under anesthesia for longer if you are to rupture something or kind of cause decreased blood supply to an organ. So it's a careful, fast, and as efficient as possible. But if you start to rush and you're really yanking on things, that can be detrimental to your surgery time. So we just want to be as careful as possible. In those acute hernias, a lot of times it just takes a little bit of just pressure and time to move that into the abdomen. Again, avoiding that excessive tension, using your hands as best you can, so that you can just use them to manipulate things so that we're not damaging lung lobes or liver or other organs. And a lot of times, if you're having difficulty or you can't quite reach your hands in, which I find a good amount of the time, it is okay to kind of open up that hernia a little bit more so that you're able to reach into the chest cavity to bring out some of those organs. You think it's going to take you more time now to suture because you've opened it a little bit, but a lot of times it's a lot safer to just open up the hernia a little bit more so that you can get in there and manipulate things easier and make it easier on those organs to move back into the abdomen. So this is going to be what that's going to look like. You can see these intestinal loops kind of moving through the hernia here. So you just want to gently pull on those intestinal loops to help move them into the abdomen. Again, when we talk about median sternotomy, when they looked at one study, it was about 28% of patients, mainly in the chronic group, that required that. And that's mainly due to adhesions, or if you're worried about blood supply, a median organ resection can be necessary for these more chronic hernias if those organs, again, are losing the blood supply. This is going to be what the median sternotomy is going to look like, which doesn't look great on the screen in here, but you can tell you've got the Finicetto retractor. They're holding the kind of mediastinum, and that's going to be the heart in the middle. And you can see a little bit of lung lobe poking out the corner here. And then that's going to be where that hernia was located. So just going to make your life difficult. Sometimes you got to go into the chest as well. When we talk about repairing the hernia or hernia raphe, it depends on whether it's radial or circumferential, but again, a lot of times it's combined. Sometimes it takes a little bit of kind of manipulating to figure out where things need to go, but it really is essentially just kind of suturing it up from that perspective. When we talk about that radial tear, we want to start as dorsal as possible and work our way ventral or to the outside or periphery. Usually simple continuous is enough from that perspective. And when we're dealing with that circumferential tear, a lot of times we have to incorporate some of the body wall or the kind of costal arch as well. So that's going to be important for those particular tears. Any absorbable monofilament, me specifically, I usually just use some form of PDS. Going to be that OCT or 0 PDS in those bigger dogs. Most smaller dogs, usually 3.0 is plenty, just to provide that apposition and that kind of airtight seal. It can be any combination of an interrupted, a continuous kind of pattern from that perspective. Again, going from dorsal to ventral. That way you're able to kind of start it and then work your way back up to where you're exposed from the midline approach. When you're going along the thoracic wall, again, anchoring it around the costal arch or the abdominal wall. Occasionally, if there's enough damage, sometimes you'll have to advance the diaphragm, which is actually just moving it a little bit further into the chest cavity, puts a little less tension on your closure, and that's a lot of times going to be that circumferential repair. And so we've got a nice big gaping hole here. We've moved the liver and everything into the abdomen. So now we're going to repair it. And as you can kind of see on the image here, they've done two simple continuous lines from here and then up to here. That's kind of dealing with the radial portion. That's going to be a part of the circumferential repair. And then this portion, they're probably going to need to wrap around either the costal arch or the body wall just to kind of get that nice airtight seal in that position. So sometimes, honestly, a lot of the times it's a combination of different ones. Sometimes if you can do an interrupted throw as like a stay suture, just to kind of bring it up to one area, it can make your overall closure a lot smoother and a lot easier. In your more chronic cases, a lot of time there's atrophy or fibrosis of the diaphragm, which can make it very difficult. You get a lot of tension on your closure. So sometimes you're unable to close it primarily, and there's different things that we can do to help alleviate that tension. It's again not great to see, but you can see how they're kind of really pulling on that diaphragm and how it's atrophied and contracted a little bit. So closure is going to be very difficult in this particular case. If you don't have that autologous tissue or that normal diaphragm to suture, omentum is one that's not going to create an airtight seal, but if you're worried about the blood supply to a certain area, tacking omentum to it can help with that blood supply. So that's where we use that particular thing. You can sometimes just kind of push the liver up against it, and a couple stay sutures can help it kind of fibrose down and close a certain area if possible. Or sometimes it just certain fascia can be incorporated into it. That wasn't normal diaphragm, but it can create that airtight seal. There are various muscle flaps, which we won't dive into, that can be also used to flip up and be incorporated into that diaphragmatic closure. Again, if you use those muscle flaps, it doesn't quite work as well as the normal diaphragm, but it's mainly just kind of creating that closure that we need so that we're able to function as normally as possible. There are certainly synthetic materials like mesh that can be utilized. However, we do worry about things like foreign body reaction, a lot of inflammation and adhesions that can happen. And if infection happens, it can be kind of very detrimental to the patient. So if we can avoid that mesh, if at all possible, it's for the better for the patient. When we're evacuating the air, that's going to be really important as we start to close that hernia. That way we don't create that tension pneumothorax. You can place the thoracostomy tube in preparation. That's probably the easiest way and the most reliable way to evacuate air. That way you're able to do monitoring postoperatively as well. You can sometimes have the thoracostomy tube pass through the hernia and out the body wall. Again, I don't recommend it, but that can be a way for you to evacuate air and then pull it out at the end of your procedure when you're getting that negative pressure. So it's just been described, not the easiest to manage from that perspective, but is an option. If you're not worried about postoperative kind of air in the chest, you can sometimes incorporate a red rubber in your closure. And then once you're pretty much closed, you can even pre-place like a mattress suture, evacuate all the air, pull that red rubber out, and then tie that last suture. So it's another way to do it. And if you're doing it, look at an image here. So you can see the red rubber here going through your hernia repair. It is a pit of a large space there, so I worry if you pull it out, it might still have a hole there. So usually having that suture pre-placed and starting to tie it while somebody pulls the catheter out is going to be the best way to maintain that negative pressure. When we're talking about prevention of very specific complications, these are ones that can happen in more chronic cases, but that dogs can develop what's called abdominal compartment syndrome. Sometimes to try to prevent that compartment syndrome, which again, we'll talk a little bit about, we can sometimes incorporate mesh in our closure. You can sometimes remove abdominal organs that don't need to be there anymore, which sounds kind of unnecessary to an extent, but if we want to increase that space and not create that extra pressure, things like the spleen don't necessarily have to be there. So that sometimes gets sacrificed when we're worried about it during surgery. And there are various other techniques like actually meshing or cutting the body wall as we're closing, just to kind of make it more surface area for the abdomen to expand to hold all those organs that hadn't been living there for such an extended period of time, more in the chronic diaphragmatic hernias. So fluids are going to be important. Pain management after surgery, just like any patient post-surgery. Antibiotics if we're concerned about wounds or infection, of course. Continuous ECG monitoring, mainly related to the spleen. If it got removed or was traumatized, they can have ventricular arrhythmias. We want to monitor for those. And if we're worried about the chest cavity, having the thoracostomy tube in will be important for monitoring for air production, especially if we're worried about the lung lobes being traumatized. They might get post-op pneumothorax because of that. So with pleural effusion, hemorrhage, pneumothorax, like we just talked about, a lot of times it can be reinflation injury as well as trauma to the lung lobes when you're manipulating those organs. So things to monitor for after the procedure, how they're breathing, infection, dehiscence, seroma, that's with any procedure. But dealing with more chronic cases, there's two specific complications that can happen. One of them is reperfusion pulmonary edema, as well as that abdominal compartment syndrome. So we'll talk a little bit more about those. So re-expansion pulmonary edema has a mortality rate in humans of about 20%, so it's a pretty serious complication. It's an uncommon inflammatory response to where once you start really perfusing those lung lobes that have been compressed for who knows how long, probably extended period of time, it can create injury to that capillary membrane, which causes really severe pulmonary edema. If it does happen, really, it's just supportive care in terms of treatment. Some of these patients need mechanical ventilation if it's severe enough. So our best case is to try to prevent it. And that's mainly having to do with that positive pressure ventilation when we're in surgery, especially for these more chronic cases. So we just want to be careful so we don't run into this complication. And then abdominal compartment syndrome is when they get that loss of domain. So the abdomens become so used to not holding all of those organs that when we start to put everything back in, there's not enough space for them to live. And when that happens, when there's not enough space and we shove all those organs in, they can lose their blood supply, can result in hypotension, hypoxia to those organs. The kidneys specifically become the most sensitive. They can have decreased renal function. And it's that even sometimes increased intracranial pressure if that issue is to progress. It can sometimes cause that depression because of that increased pressure. When we're monitoring for this after surgery, if we need to, if that's of concern, the best way to do this is actually with an indwelling urinary catheter. A lot of these patients, it's a good idea to kind of keep that bladder decompressed and to keep the stomach decompressed with the nasogastric tube. But if we have that indwelling urinary catheter in, we can actually use that to monitor that abdominal pressure. So you hook it up to a manometer of some kind when you want to evacuate it. Normal intra-abdominal pressure is anywhere from 5 to 10 millimeters of mercury. If it starts getting up into the 11 to 20 or more range, then we start to worry about loss of renal function, loss of blood supply to those organs. So then we might need to go back in and do something else in terms of the procedure to alleviate some of that compartment syndrome. And certainly monitoring the urine output is going to be important, as well as the blood pressure, because those are the things that are going to be affected more severely when they have this condition. So if you can prevent it, great. And if we need to monitor for it, I think keeping that catheter in so we're able to check it is going to be important. In terms of prognosis, unfortunately, a lot of these dogs can die prior to presentation, and that's mainly just related to the trauma that they have. However, when they present to us and they're able to go to surgery, that post-op survival is going to be good to excellent, I would say. Majority of these patients will do well. Some of the prognostic indicators that have been found. So any increase in anesthesia and surgery time is going to increase those chances of complications and issues post-operatively. Having concurrent soft tissue or orthopedic injury can cause a 4.3 times, or for ortho, 7.3 times increase in mortality rates, fortunately. And then being oxygen dependent when they come in, they have about a 5 times increase chance of mortality, unfortunately. So those are going to be some things that if you see, they're going to be more critical, of course, because they have those concurrent injuries, but it's going to affect their prognosis in the term. So just important to be transparent and be aware of those cases needing a little bit more than when they present more acutely and don't have those same issues. So just a brief case, I think we got enough time, a couple cases just to kind of review what we've talked about. So case number 1 is Max. He was a 1.5-year-old male neuter German Shepherd. He was hit by a car 2 hours prior to presentation, non-ambulatory, really poor pulse quality, very prolonged CRT. He had multiple wounds, abrasions, and the main thing that we were found on auscultation was borborygmi in that right thoracic cavity. Certainly increased our index of suspicion that something like a diaphragmatic hernia was going on. So x-rays, this was Max's x-rays coming from inside, very critical case, so very quick x-rays, but that was what we saw earlier. And so we did take him to CT, and on the CT, I think that coronal view again is going to be the best to see. So the one on the left, where you can see some of the intestines and other things moving into that left side of the thoracic cavity. Harder to see on that lateral view. And so in terms of Max's surgery, we did take him to surgery within the 24-hour window, mainly because of his just instability, but obviously getting him fluids and helping him out from that perspective was important, but we were able to take him within that 24 hours. We had to reduce the stomach, duodenum, and the transverse colon, which on the CT scan wasn't seen. So just goes to show you the dynamic nature of different organs that can move in and out of that hernia while they're being positioned for surgery and everything else. It was actually a right-sided tear, so it was flipped around on that CT image. I apologize. And we just used a nice 3/0 PDS simple continuous suture line. And in order to deflate the diaphragm, we ended up not placing a thoracostomy tube, and we just, after we closed, placed an 18-gauge catheter through the diaphragm, and you can actually use that to provide negative pressure. So it's another option to evacuate air. We placed some IV fluids, fentanyl post-op, some Unison due to those wounds and abrasions, monitored continuous ECG, did have some AIVR, which we didn't treat, and a little bit of AV block, but we noted that post-operatively, and then did eventually have to go over to our orthopedic department for fracture stabilization. And being myself, I do have to kind of show the orthopedic injury x-rays. So it was a radius ulnar fracture that was repaired with 2 plates here, which is kind of cool. And then Max did end up having a deranged stifle, injury to the cranial cruciate ligament and the medial collateral ligament. So we had to repair both of those with a lovely TPLO. And then there was actually a volsed off the cruciate ligament. So we placed a screw just to hold that bone in place. And then we had to place some suture to recreate that collateral ligament. So Max had a lot of things done to him. But the good news is Max did great, was discharged. As far as I know, is living a happy life as a German Shepherd. Hopefully not being hit by cars anymore, but was doing very well at the time of recheck. So the other case is Toby, which I had on a weekend in the middle of the night, of course, as these tend to go. But Toby was a weird case in that he was a 10-month-old male-neutered Cavalier King Charles Spaniel. He supposedly vomited a few times in the morning, was very painful, however, after he came back from a walk, and then started having respiratory difficulties. So mom came in, it was the evening walk, so later in the evening, was really not doing great. They did a CBC chem, some inflammation, some increased liver enzymes, nothing super specific. But when they took x-rays, kind of hard to see, but you can see this nice big gas bubble hanging out here in that kind of caudal dorsal portion of the lungs, and some things maybe missing in the abdomen specifically. Well, we did end up doing a CT scan, and you can kind of see, especially that coronal view, we've got this kind of gas and everything within the chest cavity here on the right. And then it's kind of hard to see, but this is where the normal abdominal organs are. You can see how gas distended some of those intestinal loops are, but certainly some stomach within the chest cavity. There we go. And so these wonderful Cavalier King Charles Spaniels actually have a congenital pleuroperitoneal hernia that can happen. It is an autosomal recessive inheritance. It's mainly a presentation of herniation of the stomach with sometimes the spleen and small intestines, just based on the location. And so, again, it's predisposed in Cavalier King Charles, according to studies in the corner there. And when they looked at these particular cases that were presenting, they had a case series within the literature of 5 cases that had this very specific acute onset respiratory distress. And it was mainly because the stomach was occupying that left caudal thorax. And it is mainly due to a defect of the left cruce, which then leads to what they call a tension gastrothorax, where the stomach is allowed to herniate through and then it fills up with a bunch of air and they have this acute respiratory presentation. All of the patients in that particular study did survive to discharge with no complications. Of course, I did not know this at 2 in the morning, but we still took the dog to surgery, but it was nice to see that afterwards, that this has happened in other people and other Cavalier King Charles. So Toby's surgery actually went fairly smoothly. It was a horizontal rent within that left cruce, so that dorsal made it hard to manipulate and see what we were doing, but we were able to reduce the spleen and the stomach that herniated through the diaphragm, and that stomach was actually rotated as well, so would probably have lost its blood supply if left there for too long. We did have to extend the rent just because the stomach does fill up with so much gas. In order to kind of bring all that back in, we had to open it up a little bit. We just had a nice 3/0 PDS simple continuous suture line, and then we use the red rubber pass through the suture line to evacuate the chest cavity. So we watched him very carefully after the procedure, could care less, very normal respirations, gave him some IV fluids and some analgesia, monitored his ECG, that was totally normal, even though the spleen was involved in the hernia, and at about 36 hours was discharged and had no issues of follow-up, was doing very well, despite the acute presentation and the respiratory compromise, still had a very good prognosis, similar to his other friends that were in that case series, as we talked about. So it's not always the trauma that can happen. I think anything coming in with the respiratory issues, compromise, take those chest x-rays. Sometimes it can be a weird thing like Toby, where we had this acute gastrophorax presentation. So in summary, when we're talking about diaphragmatic hernias, that stabilization is going to be very important. Monitoring very closely, especially under anesthesia. You want to be very cautious if it's that chronic hernia, just because we're more worried about issues that we're going to have in surgery. And overall, most dogs presenting for diaphragmatic hernias that go to surgery have a very good prognosis. So again, just reviewing our objectives, we talked about the anatomy and physiology, which everybody loved, the presentation of these. Obviously, any trauma patients can potentially have a diaphragmatic hernia. Review diagnostic approach. Again, we talked about the thoracic abdominal imaging being necessary for these patients for diagnosis. And certainly some challenges with anesthetic management. We want that rapid induction. Monitoring is going to be very important, and the positioning is going to be very important as well. And surgery, it's going to be important to reduce and be careful when we're reducing those organs, repairing the hernia, and then creating that negative pressure again. And with that, I will take any questions. Anybody?
Is there any benefit to monitoring ultrasound blood flow instead of having to do the urinary catheter?
Yeah. Danielle asked us if it's important to maybe monitor with ultrasound that venous blood flow, I'm assuming, as opposed to doing the indwelling catheter. I think the concern is, well, yes, the ultrasound might show that reduction in blood flow. The pressure decision-making becomes hard, mainly because they can sometimes have an issue in that initial phase and still do okay. So they might be hanging out in the 7 or not, yeah, like the 5 to 7 range. But if it starts to creep up, and monitoring their kind of urine production and their overall blood pressure, I think is the maybe easiest and most consistent way. But if you have radiology and they're able to pop a ultrasound probe on, if you're trying to make that final decision of needing to go back to surgery or not, that can be beneficial, I think. So, but overall, I think just monitoring their blood pressure as best you can consistently and their urine production. Sweet.
Do the Cavaliers ever re-herniate?
Nope. Yep, not at least in that case series. They followed them up for, I think, a year or so after their procedure, and they all were doing fantastic. So, yeah. Oh, cavies, right? Another thing to add to the list. Yep. All right.
Not any questions?
Chat.
Anyone at home have any questions? Caroline says thank you. All right. I think that's it for today then.
Everybody have a good day. Thanks for listening. Appreciate it.
Thank you.
Thanks for organizing.
Yeah.